So one of the comments that you had made at a previous meeting involved younger pediatric patients not being able to audibly express themselves to define what hurts and how and where. So how does the board protect public health in a manner to make sure something isn't missed in an audio-visual encounter with a 2-year-old or so?
So I think that is something that we would address by keeping the primary provider in the loop. I don't think that children can necessarily articulate, and it's not just necessarily based on age, but also developmental status. So you can have a 12-year-old who can't articulate a problem. So I think if you have a caregiver, parent, guardian, who is able to give consent and to give information to the provider, that telemedicine can be a venue or a way to provide care. But I also think that in some circumstances, that child needs to have a referral in all circumstances, back to the primary care provider. But I think that we need to be careful with our language so we don't exclude children from telemedicine just because of their age.
So I'm going to pick up on it. I feel like Phil on you for a second, so forgive me for following something like this. But so you just said in all circumstances referral back to the primary care physician. Is that something?
Primary provider.
Primary provider. Is that something that should be mandatory in the board's suggested rule, or is that because what in some cases there may not be a primary provider? So help me understand.
Well, I think that would be definitely a minority of patients in Arkansas in terms of pediatrics. Because most children have a primary care provider. They may not be seeing that provider, but they have one listed. So, what is the question? I'm sorry, can you repeat that question?
Well, you just made the comment that you felt that regardless of age, that the patient should be, for lack of a better word, followed up with by a local primary care provider.
Well, not necessarily followed up, but at least in the loop of what's going on with the patient. So I think that documentation piece in terms of getting the information back to the primary care provider is key. In particular for, I'm biased because I see children, but I think in particular for children, they need to have someone who is overseeing their care, the developmental status, and they're probably at higher risk of having things missed because they aren't able to articulate their problems. So, having the primary care provider in the loop, whether that's via email or sharing records, we can talk about the specifics of that, but I think that is key for pediatrics.
Dr. Lally, I think you got a comment?
Well,
use your mic.
Yeah, I agree with Tamara. And I've been big advocate of telemedicine for many years, but it's not the same as being in person. It will never be the same as being in person. There are limits to this stuff. And particularly when you're asking the parents or a lay person to render an opinion about what's going on. And so I think we have to be really careful that we don't slip on that issue. And what Tamara's saying is exactly right. You're asking the parents to be a diagnostician. The patient, particularly if it's something like looking in the ear and you don't have an otoscope to do that. So one of the things that we kind of said that I don't think you should hold telemedicine to any higher standard than in person, but I don't think you should hold telemedicine to any lower standard than in person as well. So I think it should be equivalent. In the paragraphs that I kind of recommended on B, section 2, patient must provide informed consent to the patient. Treatment is done. Treatment, though not in person, real-time interaction, audio and visual, encounter digital stethoscope, laryngoscope, or other scopes as necessary, especially. I would kind of like to amend that to say as needed to support the standards of care based on the symptoms of the presenting disease instead of especially. Because that would imply that unless you're an ENT guy, you wouldn't necessarily have to have a otoscope, to look at somebody's ears. And I think it kind of needs to be more symptoms-based, the equivalent of being in person. You understand what I'm saying? In that case, what you're asking telemedicine to do is to be equivalent to an in-person visit. If the average physician would look at somebody's ear, if the mama says, I think the kid's got an ear infection, then you need to be able to do that by telemedicine. Otherwise, you're substandard.
Okay. When you're talking about children and adolescents, and you're talking 6 years age, are you setting an age group under? It wouldn't be allowed at a certain age, or?
Well, I'm not saying age. I can make.
But I mean that was.
Guilty at it.
And that was the 6 years came from. If you're going to say 6, why not say 8 or why?
Right. I mean, there's no difference in the 6
I see what Dr. Perry's saying. I'll take out the age, just put, I suppose, anyone under 18
Needs parental consent.
needs parental consent.
We have to do that now. I see a minor patient in my clinic. I can't treat that patient regardless of age or complaint unless the parent consents to having anything with him.
Let me tell you another thing you said. We've been doing this telemedicine for so long. We do ultrasounds on the patients, and if we can't see adequately on the ultrasound, we refer the patient to the tertiary care center to look at the patient. If we feel like the exam is adequate, based on standard of care, then we don't necessarily refer them to. So I think telemedicine should be handled to that same standard. So if you can, got the tools, you can see what you need to see, and that's kind of what you're saying too. But if you don't see what you're supposed to see, and you don't feel comfortable, it needs to go to the primary care physician, whether that's emergency at night, urgent care, or the doctor's office the next day. But you've got a plan for that.